Welcome to this presentation on the guideline for the evaluation of cholestatic jaundice in infants. This clinical pathway, designed for pediatric fellows, is based on the joint recommendations of NASPAG and ESPAG. Finding the cause of jaundice in a newborn can feel like looking for a needle in a haystack. While many infants appear jaundiced, cholestasis affects 1 in 2,500 term infants and is always pathologic. Because visual estimation of bilirubin is inherently inaccurate, fractionation is strictly required to distinguish it from physiologic jaundice. Early detection is vital for optimizing time-sensitive treatment plans. We are in a race against time when it comes to biliary atresia, which accounts for 25 to 40% of neonatal cholestasis cases. If bile flow is established before 60 days of life, approximately 70% of patients succeed. However, this success rate drops to less than 25% after 90 days. Currently, a clinical gap exists in the U.S., where the average age for surgery is 61 days. The 14-day mark is our critical intervention threshold. Any infant still jaundiced at 2 weeks requires a targeted evaluation. For formula-fed infants, you must fractionate bilirubin at 14 days. For breastfed infants with a normal physical exam and no dark urine or acholic stools, you may monitor until 3 weeks. However, if they remain icteric, you must check total and direct bilirubin. We define the pathological threshold strictly. Any direct or conjugated bilirubin level greater than 1.0 milligrams per deciliter is considered abnormal. Please note that the historical 20% of total bilirubin rule is now obsolete due to the physiological complexity of canalicular transporters. Always look for diagnostic red flags in the clinical history. Consider prenatal findings like choledochal cysts or maternal cholestasis, and infant demographics like prematurity. Watch for presentation flags. Delayed meconium suggests cystic fibrosis, vomiting or lethargy suggests metabolic disease or sepsis, and excessive bleeding points to coagulopathy or vitamin K deficiency. A thorough physical exam is essential, looking for hepatomegaly, splenomegaly, or murmurs associated with Alagille syndrome. Direct visualization of stool pigment is mandatory. Acholic or pale stools indicate biliary obstruction, but remember that healthcare providers only correctly identify them 63% of the time, so you must view the stool directly. Tier 1 investigations act as the top of our diagnostic funnel. This includes a comprehensive blood panel checking liver function, GGTP, and INR, as well as screening for alpha-1 antitrypsin and thyroid function. We also perform a urinalysis to rule out galactosemia and a fasting abdominal ultrasound as the primary imaging step. If Tier 1 results are inconclusive, we move to Tier 2 investigations, which must be customized in concert with a hepatology specialist. This stage explores metabolic disorders, infectious causes like CMV or herpes, genetic testing for Alagille or cystic fibrosis, and endocrine evaluations to rule out panhypopituitariness. When interpreting imaging, remember that a fasting ultrasound primarily rules out choledochal cysts and may show a triangular cord sign. While hepatobiliary scintigraphy has high sensitivity, it has limited specificity. A non-excreting scan does not confirm biliary atresia, and scintigraphy should never be used as a standalone diagnostic tool for confirmation. Liver biopsy remains the diagnostic cornerstone. When interpreted by an experienced pediatric pathologist, it provides a correct diagnosis in 90 to 95% of cases. It allows us to distinguish between biliary atresia, characterized by bile duct proliferation and fibrosis, and idiopathic neonatal hepatitis, characterized by lobular disarray and giant cell transformation. The gold standard for diagnosis is the intraoperative cholangiogram, providing direct visualization of the duct remnant. Before surgery, we must rule out Alagille syndrome and cystic fibrosis to avoid unnecessary procedures. If the cholangiogram confirms biliary atresia through the non-visualization of a patent extrahepatic tree, an immediate Kasai procedure is performed. Use GGTP as a guide for your differential diagnosis. Low or normal GGTP levels, which are out of proportion to the level of cholestasis, suggest conditions like PFIC types 1 and 2 or bile acid synthesis defects. Elevated GGTP levels are more common in Alagille syndrome, PFIC type 3, and alpha-1 antitrypsin deficiency. Be aware of key non-biliary atresia etiologies that can be medical emergencies. These include alpha-1 antitrypsin deficiency, the most common inherited cause, panhypopituitariness, which carries a risk of hypoglycemia and shock, CMV infections, and metabolic crises like galactosemia, which require checking the newborn screen. Finally, this master clinical algorithm summarizes the pathway. We begin with fractionation at 14 days, confirm if direct bilirubin is above 1.0, conduct Tier 1 labs and imaging, exclude medical mimics, and proceed to biopsy for pathological confirmation. Our ultimate target is to reach the intraoperative cholangiogram and Kasai procedure within 60 days of life.